Acute coronary syndrome, or ACS, is one of the can't-miss diagnoses that must be ruled out when a patient presents with acute chest pain. ACS is caused by sudden decreased coronary blood flow, also known as cardiac ischemia. The three types are ST elevation myocardial infarction, or STEMI, non-ST elevation myocardial infarction, or NSTEMI, and unstable angina, where the latter two are collectively referred to as non-ST elevation, or NSTEACS. STEMI results from complete acute blockage of a coronary artery, leading to a transmural infarct of the myocardial wall supplied by that artery. NSTEMI results from a supply and demand mismatch, leading to non-transmural subendocardial infarct. Lastly, unstable angina also results from a supply and demand mismatch, leading to myocardial ischemia, but hasn't yet caused infarction. The first step in approaching a patient with chest pain is to do an initial assessment with a focused history and physical examination, or H&P, along with a 12-lead ECG. Prompt ECG should be obtained within 10 minutes of hospital arrival and shouldn't be delayed by H&P. When chest pain is due to cardiac ischemia, it usually worsens with exertion, is not relieved with rest, and doesn't change with body positioning. Some patients may complain of chest discomfort, pressure, tightness, or burning-like sensation, as well as palpitations, dyspnea, diaphoresis, nausea and vomiting, dizziness, and syncope. Ischemic chest pain often radiates to other parts of the body, including the epigastrium, left shoulder and arm, neck, and lower jaw. Relevant medical history in patients with chest pain includes hypertension, dyslipidemia, diabetes, tobacco use, and a family history of myocardial infarctions. Physical examination findings in patients with ACS can be variable, since proximal blockages in large vessels result in more myocardial damage than distal blockages in smaller branches. If a large myocardial area is affected, it can lead to decreased cardiac output. As a result, physical examination may show signs of cardiogenic shock, such as hypotension, tachycardia, diaphoresis, cool extremities, and pale skin. In addition, some patients may have evidence of acute heart failure, which is characterized by jugular venous distension, crackles on lung auscultation, new S3 gallop, new or worsening murmur, orthopnea, and edema. If there's suspicion of ACS based on H&P, markers of myocardial injury like troponin should be obtained. Some high-yield facts to keep in mind. If a patient has a history of stable angina, changes in their presentation that may suggest ACS include chest pain at rest for more than 20 minutes at a time, new onset chest pain that greatly limits their physical activity, or a change from their baseline angina in terms of frequency, duration, or onset of chest pain with less exertion. Also, some patients, particularly both cis and trans females, older patients, and those with diabetes, may present with dyspnea rather than chest pain. While performing the initial assessment, establish IV access and attach cardiac and oxygen saturation monitors. Then, start MONA. M is for morphine, which is administered IV to manage pain. O stands for oxygen supplementation, which might be needed to maintain the patient's O2 saturation above 90%. N is for nitrates, which can be administered sublingually or less commonly IV for vasodilation to improve blood flow to the myocardium. Lastly, A is for high-dose aspirin, which is 325 milligrams, and it's given for its antiplatelet properties to prevent complete thrombosis. In addition to MONA, also give a high-intensity statin, like high-dose atorvastatin to stabilize the plaque. Finally, give a beta blocker, like metoprolol, to decrease myocardial oxygen demand and decrease mortality. Okay, now that you've done the initial assessments and acute management, it's time to check the ECG results for STEMI. If ST segment elevation is seen in 2 contiguous leads, it confirms the diagnosis of STEMI. However, a left bundle branch block, or LBBB, can mask ST elevation, So the diagnosis can also be made if there's a new LBBB with a presentation consistent with ACS. LBBB typically presents as QRS longer than 120 milliseconds, a dominant S wave in V1, broad-notched R waves, and absent Q waves in the lateral leads, like V6. Once a STEMI diagnosis is made, get a cardiology consultation to help guide management steps. The primary goal of treatment should be to quickly reperfuse the ischemic tissue to limit myocardial necrosis. But first, additional medical therapy needs to be given as long as it does not delay starting reperfusion therapy. All patients should receive dual antiplatelet therapy, or DAPT, which includes adding an oral antiplatelet medication on top of the aspirin they have already received. Similarly, they should also receive an anticoagulant to reduce the risk of thrombosis-related ischemic events. Now, let's look at the options for reperfusion therapy. If it's been less than 12 hours since the symptoms started, reperfusion therapy can still help salvage the myocardial tissue without causing large-scale reperfusion injury. If it's available within 90 minutes after the patient made first medical contact, the treatment of choice is percutaneous coronary intervention, or PCI. Coronary angiography is done first to detect the number and degree of coronary artery blockage. Then, during the PCI, a balloon catheter is advanced past the blockage and inflated to expand the blocked artery, and a stent is left in place to keep it open. If PCI is not available within 90 minutes, fibrinolytics like TPA can be given to break down the clot in the coronary artery if there are no contraindications. If a STEMI is identified and it has been more than 12 hours since the symptoms started, there could be large areas of myocardial necrosis. When reperfused, damaged cells can generate free oxygen radicals that further damage the myocardium and trigger more inflammation. Thus, it's important to assess for evidence of ongoing ischemia. This is characterized by refractory chest pain, hemodynamic instability, dynamic ECG changes, and ventricular arrhythmias. If any of these signs is present, PCI could still be pursued to prevent further ischemic damage. If these are not present, the STEMI should be managed with continued medical therapy. Okay, now let's look at non-ST elevation acute coronary syndrome, or NSTE-ACS. On ECG, there is no ST elevation, and the initial ECG shows ST segment depressions, T-wave inversions, or pathological Q waves. This could be either NSTEMI or unstable angina. So the next step to differentiate these two is to measure troponin levels. In NSTEMI, there's an elevation in troponin that indicates myocardial infarction. In unstable angina, the ischemia is not severe enough to cause myocardial infarction, so there's no release of troponin. So if NSTEMI is identified, get a cardiology consultation and start dual antiplatelet therapy as well as an anticoagulant. Then, assess the patient for evidence of ongoing ischemic injury. If there's no evidence, the patient should continue medical therapy. On the other hand, if they do show evidence, they'll need urgent coronary angiography. Based on the findings, they can either get immediate PCI or coronary artery bypass surgery, also known as CABG. Some of the main indications for CABG include multivessel involvement or left main coronary artery disease. This is because CABG provides more complete revascularization and has better outcomes than PCI in these situations. Now, if troponin levels are normal, unstable angina is diagnosed. The patient should undergo early risk stratification. Some scores used clinically include the Thrombosis and Myocardial Infarction, or TIMI score, and the Global Registry of Acute Coronary Events, or GRACE score. Patients at high risk for adverse events should undergo angiography within 24 hours. If unstable angina is diagnosed, they should start antiplatelet and anticoagulants. Then PCI or CABG based on findings. Patients at low risk should undergo non-invasive stress testing. If the stress test is abnormal, coronary angiography is needed to confirm the diagnosis, followed by antiplatelet and anticoagulants, then PCI, or CABG. If it's normal, alternate diagnoses should be considered. It's important to note that fibrinolysis is never indicated for NSTEMI and unstable angina. Finally, sometimes the ECG will be non-diagnostic. When the initial ECG shows no abnormalities, but the H&P still raises concern for ACS, it's important to repeat serial ECG and troponin to assess for any changes. If the ECGs and troponin remain negative after serial monitoring, non-invasive stress testing should be performed as the final step to rule out ACS. If this is normal, alternate diagnoses should be considered. Any abnormalities during serial ECG, troponin, or stress test should be followed up with angiography. Alright, as a quick recap, acute coronary syndrome presents with chest pain that's not relieved with rest and doesn't change with body positioning. The first step in approaching a patient with chest pain is to obtain focused H&P and a 12-lead ECG. While performing the initial assessment, start MONA, which stands for morphine, oxygen, nitrates, and aspirin, followed by a statin and a beta blocker. Once you have the ECG results, if there's ST elevation in 2 contiguous leads, it's a STEMI. If there's no ST elevation, measure troponin, which will be elevated in NSTEMI and normal in unstable angina. Patients should be assessed to choose appropriate treatment and get reperfusion therapy as soon as possible when appropriate.